So C6 level. I mentioned, I know it's not fully correct, but I call it my super quads. The individuals that meet and or exceed expectations that you may hold for them and or that the textbook charts may hold for them. So the super C6s are able to roll independently. Other C6ers, once again, that's not politically correct anymore, is it? Have more difficulty, may need a special setup or distal and fixed to perform the task. So, C6 that is able to do this task independently. I'll first demonstrate. Okay. So, easy looking task? No. Time efficient? No. Energy efficient? No. But necessary for many individuals, okay? And it takes a long time for individuals to put all this together. So let's review some of the strategies we were using. Okay. Gravity, because an individual has biceps and no triceps, and I want extended upper extremities, I'm going to use gravity and externally rotate my arms. Okay. Then I create a long lever arm, which will allow me to create more momentum. Okay. When I roll, my energy placed into the direction of the roll is important, but equally important is that same amount of energy put on the return so I can build the momentum that I need. Okay. I also use my head to help, and at the very end, as I roll, I'm going to protract my shoulder and reach.
And you saw how that finished the pelvis coming over.
Because of the passive tension in my low back muscles, as I rotate my upper body in a rolling pattern, it's going to help bring that pelvis over at the same time. Plus, by protracting the shoulder, what I need to do with any activity is take my body mass and move it from behind my fulcrum point, which is my shoulder, to in front of it. And by doing a protracted reach, I'm moving that upper quadrant of my body forward and over my shoulder. Okay? The other thing is I'm able to elevate my arms 30, perhaps 45 degrees into the air to allow me to have a greater swing. If I brought my arms higher than that, without triceps, what would happen? I'd probably slap myself in the face, which initially happens frequently in initial training, so be prepared to catch those arms. Okay? So I'm using, the rolling, I'm using my partially innervated clavicular fibers in my pec. I'm using my partially innervated anterior deltoid as prime movers in this activity. Now at the C7 level, okay, we have more innervation, greater strength, and we have a more efficient rolling pattern. So C7 is able to bring their arms perpendicular to the mat and roll. So at the C6 level, if I'm going to assist Jared with rolling, okay, depending on where I see he's having some difficulty is where I'm going to provide the assistance. So let's just watch Jared roll. I'm subbing today, so I'm not familiar with how he rolls. Jared, show me how you and your therapist have been working on your rolling pattern at C6. Automatically, those arms are too high.
Okay. Oh, just like that? Okay.
So I'm going to keep your arms a little lower.
Okay.
Externally rotate, use gravity to assist and replace triceps. Okay, and now roll. What do you think of momentum? Kind of like a wet fish, right?
It's okay, but so far you got right.
Okay, so what do I need to do? Perhaps I need to take his arms. Okay, Jared, let's do some rolling. This is what I want to see. One, left, and right, and left. Jared. Okay, ready?
Yep.
One, left, and right, and left, and right. Come on, let's go. Left, and right, and left, and right. Now you're going to roll. Go, 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 roll. Okay. So I might need to assist him at his arms, give him that kinesthetic awareness that we were talking about earlier on that he was unaware of. If he's not moving his head sufficiently well, I may put my contacts at his head and help him roll. Okay? I may, if I'm wanting him to roll to his left and he's having some difficulty, more than a little, I might cross one leg over the other to help elevate his pelvis and give him a head start with his rolling pattern. I may place a towel roll at the base of his pelvis or a pillow to start bringing him 3/4 of the way into a rolling pattern. And so he's not working against gravity initially. It will impede his ability to use arm for momentum, but might give him a concept that he didn't have before that. Okay. And the last thing I'm using is my voice. Okay. If any of you have been in athletics or any type of sporting activity, if your coach kind of talks to you, you know, next time, I want you to jump just a little higher, or maybe run a little bit faster. What does that do to you? But the coach says, get up there and get this done. Lift those knees up, run on your knees. Go, 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 using the voice. Okay? So if you're in a rehab setting, you should hear chatter, and you should hear cheering, and you should hear racket once in a while, and you should be one of those people providing that. Okay?
The other thing is notice when she says it. She says it kind of, think of her doing like a quick stretch with her voice. She does it right at that transition point, right when she wants that change. That's the right time to use the voice.
The other thing that I didn't see so much is shoulder protraction with this individual. Okay, so hear it. That's part of that skill, the skill prerequisites. Maybe I need to back up and work on shoulder protraction a little bit, and we'll talk about that.
You want to do it now? Should we just do it now?
Go ahead.
So if let's say I position him in side length, so I'm going to have you come closer just so that makes my life easier, so we know how well I climb on the mat, okay? So I might put him here, I have a pillow behind him, he's at C6. So once I put him on this side, unless he keeps his arm like this, which is, I mean, it's hard to get fully externally rotated, it's going to keep collapsing at the elbow. But I really want to work on the shoulder. So I could just work on the shoulder, but I have a tendency, since it's shoulder protraction with a long lever arm, I'm going to come in, I'm going to position his arm, and I'm going to lock out his elbow. Okay, closed chain. All right, quasi close. And we're going to work on, okay, I want you to reach. Good, and pull back. Now reach forward, reach, good. And reach. And you're going to use whatever cue you're going to use in rolling. So I don't want him to do this every time he goes back and forth. It's just on the last one. It's just on that final one where we're going to go reach or punch, or Barb talks about using a mirror here and having them practice punching at the mirror so that they learn to use that scapula to come forward. So I literally can start with rhythmic initiation. Let me just move through it. Just add some resistance, push, bring back. That's what I'm trying to get. And this closed chain position works really well. But if I'm having trouble or he's not stretching out yet, I can come in and just work on the scapula itself. Thanks. What if the person is still in a halo? Still use the arms. So they won't maybe become independent yet. But Barb, would you still teach parts of this?
Just maybe more patient education at this point. What my expectations are going to be when that's removed.
Mm-hmm.
But yes, some of the arm movements, I can certainly work on strength.
You can work on side lying and do the scapular part, but you can't usually do the whole thing, right? So depending on what external fixators they have, we may be just taking them through it, doing some hard practice, which means if people wear their orthotics 6 to 8 weeks, are they going to be independent in bed mobility before they go home? Probably not. And I think that's one of the big changes we've seen during our career. Is we used to keep people long enough to get independent, and now they go home before they're independent. So we do much more caregiver training, and then a lot of this falls in the outpatient realm more than we used to.
Yeah. And if the insurance will cover, oftentimes individuals, once the external fixator is removed, are allowed to come back for a short tune-up on inpatient, which is really helpful. And a multidisciplinary team then to assist.
One of the things is when you're using momentum, to use language you're familiar with. It really is a series of movements, plyometric loading and firing back. So it's that load and go kind of idea. It's not flop, 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 because then you've lost the momentum in between. So that's what we're talking about with momentum. So if that helps. I don't know. And Barb will show you in a minute another handhold that she likes for protraction, which is hard. But we're going to move into prone on elbows. And why do we need prone on elbows? And what happens if we roll and land on our arms?
Which a lot of you question, rightly so. So, as a therapist and as the patient, we need to plan ahead. Where is this movement going to take them? What's the next step? Are we bringing them into a better position or a less viable position for future movement patterns? Okay, so we're talking about prone on elbows, or no, prone, coming to prone on elbows.
Wait, can I interrupt you one quick
sure
second?
can.
While you're thinking. So, why do we teach them rolling, by the way? What else is good for rolling beside, I mean, why roll?
Pressure relief.
Pressure relief,
To transfer on a bed.
transfer out of bed.
Agency, so they feel like they can move themselves.
Another really big reason.
Bed to work?
No, sure, for moving for bedpan potentially, and maybe for dressing. I mean, I know OT traditionally teaches more dressing and that sort of thing, but we certainly help them have the skill set for that. And rolling is one of the critical ones for lower body dressing.
From prone to prone on elbows. Okay, first to answer the question people had, what happens when you roll prone and you end up lying on your arm? What happens then? The answer is you're stuck. So don't get there in the first place. Okay? So if I'm rolling if C6 or C7, if I'm rolling prone, what I need to do is maybe get this arm up in the air so I land this way. Or as I roll, I tuck this arm in, so I roll over it and immediately up onto prone on elbows if that's my goal. Okay. So individuals with SCI, I liken it to a game of chess. They need to think 2 or 3 plays ahead of where they are right now to anticipate the situations they might find themselves in and rectify that. That's a lot of problem solving. All right, so prone. I'm prone and I would like to get up into prone on elbows. If my arms are out extended in front of me, okay, what I can use is my posterior deltoid, lats if I have them, and pull my elbows back underneath me. Okay? If you saw it was a series of small little digs, I call them, which is a series of weight shifts. With the individual with SCI, anytime there is movement, there's also an associated weight shift. Because if I'm going to be moving my right elbow, I need to unweight my right elbow to create for the ability of movement, and then shift weight onto that right elbow to allow movement in my left side. So you're going to be seeing a lot of weight shifting back and forth, and that needs to precede the movement that I'm attempting.
So what's she using to do the weight shift, by the way? Watch her do this again. Where's the weight shift coming from? The head. The head to start with. And once she gets the arm back enough that she can get a little scapular or shoulder girdle help, she does. But it starts with the head.
Some individuals prefer to have their arms out to the side and shoulder ADD. And pull in. Okay. Using pec major and anterior deltoid. Some individuals prefer having their arms to their sides and using shoulder flexion. Bring themselves up. So if people are using this technique, and I think this is one I see most often, I tell my person, pretend as if you're trying to push your body back slide it backwards on the mat. Okay? And those are the 3.
So why would you want them in prone and elbows? Then we'll talk about, so those are the 3 main ways and some activities in prone and elbow. Why even go there?
You can push back the quadruped.
Yeah, so it can be a transition, right? It might be a transition into forward point, it might be a transition in eventually getting up into sitting. So it's a transitional movement, definitely. What else?
Like in kids, we talked about interacting with your environment in that position. So like if they're reading or something in that position.
Yeah, and why would we want adults to be able to do that? I mean, how often do you lay in prone and elbows? Some, maybe watch TV, stretch out your back, stretch out the front of your hips, especially if you're sitting all day long. Oh, maybe that's why, yeah. So that might be a reason, a way to do some self-stretch. And then for scapular strengthening, as we go on with more and more of these activities, scapular strength is going to be huge. And this is a great position for that.
It's a wonderful abdominal stretch. And when you picture individuals with spinal cord injury frequently sitting in your chair, you see them sitting in a posterior pelvic tilt with their rib cage down upon their hips and their abdominals tighten up, which can lead to more spasticity issues. So this is a wonderful stretch for lower extremities and trunk.
I guess, but what's the downside? What's the downside to prone lying or prone on elbows for this population?
Elbows getting the skin on elbows.
Well, prone on elbows and toughness on skin, yeah, that can be. So we have to protect those elbows. How about breathing? Barb, you want to talk about breathing in prone? I forgot to do that with the last one.
So the cervical level and upper thoracic level SCI do diaphragmatic breathing. They have poor or no innervation of the intercostals or the abdominals. So when you think of good diaphragmatic breathing results in the rising of the abdomen, or the distension of the abdomen. When a person is prone lying, the diaphragm is not as effective. And some people will have a little bit of anxiety, at least initially prone lying, with their breathing. So just be aware of that. Prone on elbow activities is improving somebody's skill set. If we think of some of the movements that we're going to be talking about here in these labs, prone on elbows is a transitional phase. So we'd like strength in the scapula as much as possible. So I can place them, she can get herself into prone on elbows, wonderful. If I need to place her there, that's fine. And during the initial several visits, probably placing and starting in a stability pattern is where we would be. So I'm going to ask Kylie not to sink down. There you go. So I'm going to have you hold, do some rhythmic stabilization. Okay, I can resist side to side, which is called alternating isometric, so she's not moving. Right. Push her back and forward. Okay. Then we could work on some mobility skills. We could work on elbow walking. Okay. So this is where she become proficient in that ability to weight shift, unload the opposite upper extremity, move and place it, and then perform a weight shift again. Okay? So kindly, I want you to shift over onto your right, lift up your left elbow, move it out. Shift onto your left elbow, pulling your right up. Okay, elbow walk out with the left, elbow walk in with the right. Left, right. Okay. And I'm seeing not much trunk flexibility as she's elbow walking, her whole lower body is coming with her. And other individuals will start to see a nice C curve. And that's wonderful because then I can work on some gentle stretching at the same time as I'm hitting my goal of scapular strengthening. Okay, come on back.
And how is she weight shifting? How is she weight shifting?
Yeah, good demo.
She's just collapsing to one side and then the other. And if all you want is them to have that kinesthetic awareness of stacking, she's doing it well. If my intent is scapular strengthening, how does it have to look different?
Keeping your shoulder protracted more instead of just the.
Right. Keeping it active. And that's my one comment to you is, what do you want, and make sure you're getting it. Because it's not just the elbow walk, it's not just the range. Are you looking for the strengthening as well? Then they better be protracted a bit and active in the scapula.
So I'll instruct my people to always be pushing down through the elbows a little bit. Keep that distance between the elbows and the shoulders, the mat and the shoulders along the way. Sometimes I'll place a mirror in front of them so they can watch and self-correct, which I think is extremely important. Are you still doing okay?
Can we just do alignment quick? So Barb said in passing, keep the elbows directly under the shoulders. What happens if her elbows are behind her shoulders? Yeah, no triceps. That's what you get. And you'll see people try that. They'll try this. They'll stay back a little bit, and then they'll just try, and they're not very successful. And if you're way out too far, then you don't have the stability to do anything. So really do look at that alignment. And if they're failing, check that. That's often the place.
I can have you do one arm reaching, so I'm going to take one of your hands, reach out and touch mine. And now the other. Of course, we look more like this.
Okay.
Sorry. Okay. Now, you see what she's falling into again? Yes. So if she's doing that lean, and I'm not getting the scapular stability that I'm seeking, perhaps I'm asking her to do something that's a bit too difficult above her physical abilities at this time. So maybe rather than lifting your arm and reaching, I'm just going to have you slide your arm out forward and come back and slide. And concentrate on your weight-bearing shoulder. Some good stability there. There, and come back. Now the other side. Good. And then I can move into lifting your arm up. Okay? I always check skin prior to starting activities like this. Always check skin every couple minutes initially. After that, the last thing we want is any skin issues, because they can hold back rehab for quite a while. There are different elbow pads that can be ordered from Central Supply. Sheepskin little pads that we can place on the elbows for some protection.
So interesting, that stuff we learned last semester about when all else fails, you can start replacing isometric holds, learning how to move out, learning how to... That keeps coming back. That's a recurring theme. I mean, if we can start with her getting there, cool. If she can get there herself, great. If we can skip a bunch of steps, that's fine. But don't forget, you do know how to skip it out.
I might be in a position like this. Okay, ready? Bring yourself up, up. Go, 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 go. And hold. Okay. Come back down again. Okay, and up. I might unload her as much as necessary for her to accomplish the task. As she gets better at that, of course, I'll give the responsibility back to her. I might start her in this position, okay, because now she's not fighting gravity to come up into this position. Okay, I want you to walk out only as far as you feel you are still in control, and then come back to this position. Okay, and come back up. Except you're going to be doing a weight shift side to side. Okay, come out of it, and pull yourself back into it. Nice. Okay? And I can do my weight shifting or my resistance in this position also.
And you want to jump to a high-end side elbow position?
Sure, you want to stick with me for one more? Sure. I'm going to have you turn and face out to you. Okay. Okay? Yeah. Okay. So I also work these same types of activities on the sideline on one elbow and also supine on elbows. Okay. So in a position like this, I'm going to ask her to do elbow push-ups. Okay. Sink down a little bit, come back up and hold. And sink just a little bit and back up and hold. Okay, just as we did elbow push-ups. We did do elbow push-ups in prone, maybe not.
I don't know if we did. Yeah, that's, we should have. Yeah.
We should have.
Sorry.
Coulda, shoulda, did. Okay. Now I can have her do some reaching. Okay? So we're superimposing some mobility on this now. This is difficult because she only has 1 point versus 2 points of stability on the mat. Okay? And what I'm going to teach her is that as you rotate back like this, do you feel your shoulder coming forward? Okay. Now, as you come forward, do you feel your other shoulder going backwards? Do you see how you can control your trunk movements moving forward with rotation, coming backward with rotation? Not with your trunk musculature, which you no longer is innervated, but through scapular control. Okay? And as we move on to another activity later on in this lab, you'll see how important this is. Okay? Thank you. Often get into prone isn't the most efficient thing to do, but to use as a transitional movement, moving from supine to prone, always part of that movement. So I'll demonstrate the latter first. Okay. So I'll do it in slow motion. So if I'm rolling supine to prone, and my goal is really to get prone on elbows, what I'll do most likely is roll like this, roll over my elbow, and come on up. If I stop halfway and rest, I'm then in the position that you have in one of your diagrams. Okay. Now to come up onto prone and elbow, what I need to do is my right posterior deltoid. I'm going to activate as strongly as I can and push down into the mat to start to lift my body up. But that alone won't do much. What I need to do is hit my upper body center of mass from behind my fulcrum on my shoulder to in front of it. Okay? So I have another arm using momentum and a long lever arm. I can swing that arm to move my trunk forward as I push down with this arm. And I can come over. And what the picture shows is a little bit more of using the hand on the head to stabilize. And over I go. Not something we see often. And I don't necessarily teach this as a separate skill, but I'll definitely incorporate it into the transition from supine to prone on elbows. Okay. And then the other thing we do, supine on elbows?
Oh, yeah, supine and
Okay,
elbows. And
so I
loops.
can do the same activities as supine and elbows. I can do supine and elbows, elbows push up. I can do sides, walking from side to side. I can do reaching. And when I do reaching from supine on elbows, what I do is a cross diagonal reach. Okay. So really I'm asking my left shoulder to do the majority of the work. Okay. So I'm coming up. You can see how my left shoulder controls my upper body movement.
Look at how much range has to be there to do supine and elbows.
And this takes a lot of control because you only have 1 point of control on the mat versus 2 points.
And I would say most people, when I go to do supine and elbows, I start with placing. Because I've got to make sure they have the range, and I may use weight shifting to work on the range before I do much else, or you're going to create shoulder problems, and you don't need that.
And to decrease the amount of weight going through the shoulder, oftentimes I'll just work in sideline.
Or side sitting.
Or side sitting, yes, thank you. Slowly, because I'm working on control.
Before we leave rolling completely, do you want to talk about loops, and then we'll get into getting up?
All right. So all this rolling is wonderful if you're the only person using the bed. If you're sharing the bed with somebody else and you need to roll in the middle of the night for weight shift, or it's a transitional movement to come to long sitting for self-caffeine or whatever, or medicine, then it's an issue. So you have to work on exactly how and where you're going to anchor the loop to be effective for the individual and the task they have in mind. But oftentimes at home, I'll make a loop that goes one of those. And then it's stabilized up here with Velcro or a clip or whatever a person can manage, or under their pillow. So if the person needs to do weight shifts at night, and they need assistance, we might have their partner position them into the left sideline to begin. They'll be able to roll themselves back to prone or supine 2 hours later, and then 2 hours later be able to grab a loop and pull over into sideline position. Or depending on where the loop is placed, I can use the loop to once again, hooking each time and bring myself into a position like this.
So we often, like I said, we'll take gait belts, loop a bunch of them up, play with what do they need, what works.
And I've had, you know, where I've placed it in a position like this so a person comes up this way directly rather than from a sideline position. So whatever works.
And if you starch those loops and make them, they work a little easier to get hands in, then these are just, someone just nicely did stir. But if I starch them, they're stiffer. I don't know where you're supposed to read about that, so. Notes from the clinic.
This question.
Yeah, I have a question.
Yeah.
Do you do treatments with that same technique, like stuff they can do on their own independently using that, like repetition? Like, can you use the loops to do treatment, like them doing exercises on their own?
Sure.
Like getting used to upright,
Yeah.
getting used to.
You know, I'm just so cautious. I supervise everything so closely because I'm so concerned about shoulders. These shoulders need to last as long as the individual will if they're going to remain independent. And there's so much overuse for shoulders. Because seated in a chair where you and I and standing would reach for an item at waist level, and they're seated in the chair as they reach for an item, there's shoulder elevation involved. And that constant lifting overhead creates some overuse issues down the road.
Okay, so we've done rolling, we've gotten into prone at elbows, you've gotten some mobility and some scapular stability. What about moving from horizontal to upright? So the next page, 3 pages, 4 pages in your handout have a couple different techniques of how to get from prone on elbows or side lying on elbows up to sitting. So you have the walk on elbows, the hands in pockets, and then the throw and roll. And then the 2 pages after that have that task analysis piece that we talked about with rolling. They have it broken down again for these 3 tasks. So you kind of can compare and contrast, where do I need more shoulder flexibility, where do I need more hamstring flexibility, where do I need more strength, you know, and what are some prereq skills. So Barb will show you some, we'll certainly go through some, but there are a lot of them, so don't forget those. So if you want to demonstrate them first and then. So I think today we'll make sure you've seen them and you've tried them. And then we'll come back on Thursday and pick up there with, and how do I teach it and break it down a little more.
Probably the one used most often is the one I'll show first. So I'll demonstrate it first and we'll go through the physical and skill prerequisites necessary to perform it.
She's doing the walk around. I know which one she's doing. For those of you who have to take notes.
So I come up immediately onto prone and elbows. Now I'm elbow walking. Boy, we talked about that just recently, didn't we? Okay. I elbow walk until my elbows are past my right hip. I keep my center of mass low. I hook using wrist extension and biceps. Pull, and at the same time extend my other arm and use it as a prop to bring me over. Okay. Once in a position like this, I'm balanced so I can bring myself back up. And we'll talk at the next session how we get that elbow extension if triceps is not actively present. Okay? All right, so I'm going to do it again. Elbow walking. Okay. And as I mentioned, my elbows walk past my hips. And what you start to see going on at my hips at this point. You see how my left hip is starting to drop down to the mat? Okay.
How is it getting that? gravity to a degree. Like,
And she's her head further over.
so as she's walking around, she's also walking in a bit. And what is she doing? She doesn't have triceps, so she can't be using her triceps to push down. Scabs, yeah, protraction. She's protracting, and that's what's getting that pelvis to drop.
So I'm rocking my pelvis down. And you need that. If you don't see that pelvis drop, they are not going to be successful with this. Once again, I keep my center of gravity low. If I were to come up too soon, chances are I'd fall over backwards and have to start again. If I didn't walk my elbows forward of my hips and try to come up, I would lose my balance and fall back again. Okay?
So that pelvis drop and bringing that protraction and walking far enough around really helps. Now your picture starts completely in prone, and you could start completely in prone. But if my intent is to get up, then I've already got my pelvis partially moved. How smart of me to just be on the side.
Okay, so the necessary prereqs, you can look at hamstring flexibility. Okay, so we need enough hamstring flexibility to pull this off, because we don't want the flexibility coming from the low back area. We need to be able to elbow walk successfully. We need to be able to feel comfortable shifting our weight to load and unload our arms. And we need to be able to know how to use the elbow lock-in from this position to lock our elbow sufficiently to provide arm support, arm prop, to assume and maintain long sitting. I'm going to do the hands under the distal end fixed. So in this movement, distal end fixed, your picture shows hands in the pocket. Two things that oftentimes don't work with this is the pockets are too small and you are able to get your hands in your pocket but then not out of them at the time you need to. And or most of your patients come down in athletic gear or sweatpants, and as the hands go in the pocket, the pants go up this high, so it's ineffective. So oftentimes, we'll start with hands tucked under the butt. Okay. Then what I do is bring my head up, use distal end fix via wrist extensors, and my active biceps to flex my elbows until I hit in range with that. And then immediately, I need to weight shift and bring my elbows back into a prop position. Two things. If my elbows, as I'm coming up, if my elbows are out to the side, I may be able to come up, but they're going to slide out and it's going to drop me down. So I've got to keep thinking of digging my elbows in close to my midline as I come up. Keep them underneath me. And the other thing is I need to move quickly because my biceps will only take me so far and I can only hold this position for so long before I drop out of it.
So how much can a muscle contract? How much of the length can a muscle change? Going back, 50%. A muscle can shorten 50% of its length and then it runs out of where the little, things can grab. So there's only 50%, which is not very far. So if you try this, realize that's as far as your biceps are going to hold you. The other thing, I've had lots of trouble with patients is getting their hand underneath. You saw Barb, she did weight shifting with her head. I've seen patients, they've got wrist extensions, so they'll kind of try to worm it underneath, doing a kind of a worm to try to get that hand under. But that's really hard. I don't get many patients that can do this particularly.
And some therapists will teach hook your thumb under belt loops, which I think is awful for the saddle joint of the thumb, and not good for clothes either.
Do you want to finish from that supine and elbow? How did you finish getting up to long sit?
Okay.
Yeah.
So from this position, now I'm using, when we practiced before, the skill we practiced in sideline elbow prop and shoulder control, this is where it comes in this movement. So I'm in a position like this. Come up. a lot of shoulder strength, long arm momentum. From here, use my head to unweight my shoulder.
Now, you know, he's been doing all that side lying on elbow things.
One side weight bearing through this elbow, I need to use scapular control to rotate my trunk over it, bring my body weight forward of my shoulder and elbow, and then use fast and quick momentum to shift back and hand placement, and that'll bring me up over the other side, and then
So notice her right arm head didn't land behind the plane of her body, because as soon as it lands, she's going to weight shift over it. If it's out to the side at all, it became a kickstand. And without triceps and those other muscle groups, it's not going to stay, and it's just going to fall. So you've got to make sure they've got that much range to be behind. And the minute that hand hits, she's letting her body follow so that it unweights the other elbow. Because if you end up uneven, down on elbow and out on arm, you're stuck. Without a tricep, you're stuck. You'll start all over again.
And the last technique starts prone on elbows, and then really brings in what we just discussed with this transfer.
The roll and roll.
So in this, I can bring myself back, and once again, I can't collapse down on the shoulder. I gotta bring myself up again. Bring myself up, throw this arm over, way far behind, use momentum to bring myself over and back in place.
But again, that shoulder flexibility. So if you were teaching this, what position might you start in? They've not done this at all. To make sure you're keeping them safe, where might you start? Long sitting on extended arms, making sure they have that range. You've done some weight shifting there. You've practiced just moving one arm so that they really get that before you then try to get there with your pass. Make some sense? Anything else that we didn't balance? So while this last way doesn't take as much hamstring flexibility, it takes a lot more finesse and skill and upper extremity flexibility, which is part of the reason why we almost always start with the first one, the walk around method. And we can compensate for tight hamstrings. We can put pillows underneath and stuff if we need to. We'll go through more of that next time. But that takes more hamstring flexibility, but not as much skill up top.
As people become proficient in the walk around technique, what you see is them bring themselves up.
Or doing even that throw and roll, they'll walk part way around. So they'll find ways to adapt this to themselves.